Hi, this is Dr. Pedro Ramirez, editor-in-chief of the International Journal of Gynecological Cancer. Today, I have the great pleasure of having on the podcast Dr. Santiago Vieira-Serna from the Instituto Nacional de Cancerología, Department of Gynecologic Oncology in Bogotá, Colombia. Santiago is going to be speaking with us about a recently published article titled Contralateral Pelvic Lymph Node Metastases in patients with unilateral early stage epithelial ovarian cancer, a systematic review and meta analysis. Santiago, thank you so much for accepting our invitation to speak about this article. Obviously, a topic that we want to discuss with you. Congratulations to all of the co authors on this publication. And of course, obviously, thank you for sending it to our journal. So, with that, I want to welcome you and once again, thank you for joining us in the podcast.
Thank you, Pedro, for the invitation. It's a pleasure to participate in the podcast.
Great. So, let's start actually by discussing why did you consider that exploring the topic of lymph node metastases in early stage ovarian cancer was relevant today?
Yes, of course. Historically, lymph node dissection has been considered a standard component of surgical management in ovarian cancer. However, after the publication of the Lion trial and later the Caracol trial results, the systematic lymphadenectomy is recommended only in early stage epithelial ovarian cancer and involves bilateral pelvic and parotid lymph node dissection. The therapeutic value of lymphadenectomy remains controversial, as you know. Several retrospective studies have report improving disease-free survival when lymphadenectomy is performed in early stage ovarian cancer compared to no lymphadenectomy. In clear cell carcinoma, some analyses have even suggested a possible overall survival benefit. On the other hand, randomized controlled trials showed no significant difference in 5 year progression free survival or 5 years overall survival between patients undergoing systematic lymphadenectomy and those undergoing lymph node sampling. Beyond any potential therapeutic effect, lymphadenectomy clearly has diagnostic value. It allows us to detect occult nodal metastases and ensure accurate staging. Confirming true early stage disease may allow us to omit or desescalate adjuvant chemotherapy. um, Conversely, identifying nodal involvement of stage the patients to advanced disease and support the identification for systematic chemotherapy with or without maintenance target therapy when appropriate. Um, of course, we also have to consider morbidity. A full systematic pelvic and parotid lymphadenectomy is associated with complications, and the overall incidence of lymphedema can be as high as 20%. Given the evolving role of lymphadenectomy, the growing, although still limited, evidence on sentinel lymph node biopsy in epithelial ovarian cancer, and the broader shift toward more tailored surgery or surgical approach with less morbidity, this remains a relevant topic.
So, with that, can you tell us just briefly a little bit about the three primary drainage pathways for ovarian cancer? Which of these is most likely to lead to contralateral involvement?
Yes, I think that it's a tricky question, but an important question. Uh, I believe that there could be two hypotheses to explain the contralateral involvement in a few cases. Uh, I think the first is perhaps the microscopic disease is in the contralateral side, which could be peritoneal, uterine, or ovarian disease that is occult, and it's maybe or perhaps an apparent unilateral and could lead to lymph node disease in the contralateral regions. Uh, a second hypothesis could be a retrograde lymph drainage that could cross the midline at some level, such as presacral nodes or across the corpus uterine or even the cervix. But I think that it's so difficult to explain, considering that the anatomy studies have not found connections between right and left lymphatic ovarian drainage pathway, especially studies in fetuses.
So now, can we talk a little bit about what is the primary objective of this review? And also, what's the current NCCN and the guidelines that recommend pertaining to bilateral pelvic lymph node assessment or lymphadenectomy?
Yes, the primary outcomes were the rate of isolate lymph node metastases in the contralateral hemipelvis and the rate of contralateral lymph node metastases, whether isolate or bilateral, in the pelvic field in patients with unilateral early stage epithelial ovarian cancer. Um, Regarding the guidelines, the ESMO guideline recommends that in patients with the stage 1 to 2 high-grade histologies, complete surgical resection should remain the standard approach. And this includes systematic pelvic and para-aortic lymph node dissection as part of a comprehensive staging. Um, in contrast, for low-grade histologies, such as low-grade endometrioid carcinoma or expansive mucinous carcinoma, the rate of lymph node metastasis is very low, it's less than 1%, and because of this, lymphadenectomy could be omitted. In low-grade serous carcinoma, the role of lymphadenectomy remains controversial across the guidelines. But according to NCC guidelines, for patients with apparent stage 1A to 2A disease, a comprehensive pelvic lymph node assessment is recommended. And that includes removing lymph nodes on both sides of the pelvis along the common iliac, external iliac, and internal iliac vessels, as well as from the obturador space.
So now, can we talk a little bit about the inclusion criteria? You specifically define macroscopically unilateral early stage disease. What was your criteria for this definition?
Yes, of course. For inclusion, we focus on studies on patients with macroscopically unilateral early stage epithelial ovarian cancer, FIGO stage 1 to 2, who had undergo proper surgical staging, at a minimum bilateral salpingo-oophorectomy along with both pelvic and para-aortic lymphadenectomy. Uh, we included patients whether a lymph node assessment was systematic, selective, or limited to lymph node biopsy, depending on how original authors report it. And when we say macroscopically unilateral early stage disease, we are talking about tumors that were confined to one side with or without ipsilateral spread. For example, ovarian involvement when the primary tumors was the fallopian tube.
Excellent. So let's talk a little bit more now about the results. While the contralateral rates were low in this review, you found an overall lymph node metastases of 10%. Does this align with the historical data for early stage disease?
Thank you for the question. When we look back at the earliest studies from the 1917s, evaluating lymph node involvement in early stage ovarian cancer, they report rates around 12%. Since then, other studies have found very similar results. In 2011, a review of 14 studies was published, including about 1,200 patients with all histology subtypes. The authors found that around 14% of patients with stage 1 or 2 epithelial ovarian cancer have lymph node metastases, and about 7% had para-aortic lymph node involvement, while around 4% had pelvic lymph node metastases. Um, Another review published in 2016 included 13 studies with about 1,400 patients, also covering all histological subtypes. In that analysis, the overall rate of lymph node metastases in early stage epithelial ovarian cancer was around 13%. Around 5% had pelvic lymph node metastases, 6% had para-aortic involvement, and about 4% had both para-aortic and pelvic lymph node metastases. These findings are in line with our results. As you mentioned, we found overall lymph node metastasis rate about 10 to 11%, and most that was para-aortic involvement, around 5%. Pelvic only disease was less common, about 2%, and another 2% had both pelvic and para-aortic node involved.
Okay. Now, Santiago, I wanted to ask you because a lot of the data on this topic often talks about overall complication rates, and obviously there is data on complete staging being associated with increased blood loss and complication rates. But could you gather from your review what complications were specifically related to the lymph node dissection?
Yes, unfortunately, the studies we include did not provide enough details on complications related to lymph node dissection. So we are not able to draw firm conclusions at that point. For the same reason, we also can make a reliable comparison of complication risk between unilateral and bilateral pelvic lymphadenectomies. Um, what we can say, however, is that evidence from large retrospective studies in early stage disease comparing patients who underwent lymphadenectomy when with those who did not uh, shows a clear difference in perioperative outcomes. Patients in the lymphadenectomy groups had longer operative times, greater blood loss, and a higher rate of perioperative adverse events. They also experience more severe postoperative complications than patients who did not undergo lymphadenectomy. Um, Also, in a different patients population, the Lion trial gives us an important context too. It showed that adding a lymphadenectomy to the bulking surgery clearly increased the median duration of surgery. Procedures took longer and were associated with greater blood loss. Patients in the lymphadenectomy group also need transfusion more often and were more frequently admitted to the intensive care unit after surgery. And overall, these perioperative outcomes consistently favored to the group that did not undergo lymphadenectomy. The study also reports higher complication rates in the lymphadenectomy group, including more infection, recurring antibiotics, and most operative lymph cyst, both asymptomatic and asymptomatic, a higher rate of repeat laparotomies due to complications. And when we talk about complication in unilateral early stage epithelial ovarian cancer, the comparison that really matters is between two strategies, bilateral pelvis plus para-aortic lymph node dissection versus unilateral pelvic plus para-aortic dissection. That's the head-to-head question we should be focusing on. However, is that we still don't have enough solid data to draw firm conclusions in our study.
Okay. Now, one of the questions comes from our fellows in the journal, Matteo Lovero from Gemelli Hospital in Rome. And he's asking, in your opinion, how commonly is bilateral pelvic lymphadenectomy still performed in institutions for patients with apparent early stage macroscopic unilateral ovarian cancer? What do you guys do in your center? Do you still do bilateral? Are you only doing unilateral?
Yes, actually, we follow the current international guidelines, and we perform bilateral pelvic lymphadenectomy in this setting. It's important to remember that our study is hypothesis generating, and we still need a strong, high quality data before we can confidently change practice based on these findings. And also, I believe that the major referral institutions are following the current guidelines as well.
Now, Mathilde Del from Toulouse in France, she's asking, did you identify any risk factors for contralateral lymph node involvement, like histologic subtype, tumor grade, tumor size? So, in other words, like, I don't know, endometrioid clear cells, are they more likely to have contralateral lymph node involvement? Higher grade tumors, big tumors?
Yes, that's a important question. In our systematic review, we included studies covering all subtypes of epithelial ovarian cancer. The challenge is that many of those studies don't break down outcomes by tumor grade, histologic subtype, or molecular profile. There are few papers that focus on specific histologies, but most of them didn't meet our inclusion criteria. Based on the evidence we currently have, we are not able to clearly identify risk factors for contralateral lymph node involvement. That said, it's an important question and one that really deserves to be addressed in high quality multicenter studies, especially in high grade histologies where the risk of lymph node disease is higher.
Yeah. Now, Santiago, a question from Paula Mateo here at Houston Methodist. She's asking about the quality of these studies. And she says, given that all included studies were rated as poor quality according to the Newcastle Ottawa scale, how confident should we be in the reliability of the pool estimate in this meta-analysis? And how do you think this risk of bias should influence interpretation of the conclusion?
Yes, that's an excellent question. The main source of bias in our study are confounding and selection bias. One important limitation is that we included all histological subtypes and tumor grades in the same analysis. However, the risk of lymph node metastases varies according to tumor biology. For example, in high-grade serous carcinoma, the report risk can be as high as 40% of nodal metastases. In high-grade endometrioid tumors, it's around 20%. For clear cell carcinoma, the risk is about 4 to 12% of nodal metastases. For example, in low-grade serous carcinoma, it can reach up to 20%. Whereas in low-grade endometrioid and expansive mucinous tumors, the risk is less than 1%. And this is similar with respect to the grade tumors. The incidence of lymph node metastasis is 4% in grade 1, 16% in grade 2 tumors, and up to 20% in grade 3 tumors. So This heterogeneity could have influenced our results. And another important potential source of bias is related to surgical management. The included studies differ in whether patients underwent selective or systematic lymphadenectomy, which directly affects the likelihood of detecting nodal disease. And in addition, the peritoneal staging could vary across the studies. And as you mentioned in the question, according to the Newcastle-Ottawa scale, all included studies were rated as low quality. And for all this reason, the bias could influence the conclusion and should be interpreted with caution.
So now, Santiago, I'm going to get to a question regarding isolated periodic metastases. The question is from Arthur Shu in Taiwan, and he's asking, since the isolated periodic metastases rate was 5.4%, 5.4%, does your study reinforce the necessity of periodic dissection, even if we descale pelvic dissection?
Um, yes, I think that the answer is yes. The the primary lymphatic drainage pathway of the ovary follows ovarian vessels through the infundibulopelvic ligament toward the paraortic and paracaval lymph node chains. Um, Consequently, a higher risk of nodal involvement in this region is to be expected. And in our systematic review, consistent with previous published studies, the majority of lymph node metastases were identified in the paraortic and the paracaval fields.
Very well. So, get to a question that was actually asked by several fellows, Masha Pervin from Germany, and also Carlota Sabini from Milan. Is talking about future studies. They're asking, based on your review, is it time for a prospective surgical study to test the hypothesis that contralateral pelvic lymphadenectomy can be omitted in macroscopically unilateral early stage ovarian cancer? And I would add to that, given the rarity of early stage ovarian cancer, given the high numbers of patients that you would require to actually show a difference, is this really an unrealistic proposal to actually do a prospective study to answer this question?
Yes, it's an important question. I think that it's so difficult to perform a prospective study to evaluate this topic. But I think that maybe if we have a multi-center collaboration in prospective data, we could have a reliable data. And I think it's important too because um, also emerging data in sentinel lymph nodes in early stage ovarian cancer. If we don't have a high detection rate in the sentinel lymph node technique, maybe perhaps you need to perform a complete lymphadenectomy. So when you don't have a high detection rate with sentinel lymph nodes, perhaps if the tumor is unilateral, and if we have high quality data, maybe we can perform a unilateral pelvic lymph node dissection and paraortic lymph node dissection to detect occult nodal metastases.
Now, you mentioned an interesting point. Of course, obviously, and this would come up, the topic of sentinel lymph nodes. And the question comes from Mateo Lovero, again at Gemelli, and he says, in this era of surgical de-escalation, Do you see a future for sentinel lymph node approach in early stage ovarian cancer? What do you think are the limitations that have prevented this from becoming a standard of care?
Yes, I do believe there is a future for sentinel lymph node mapping in early stage epithelial ovarian cancer. However, at the present time, the technique has still important limitations. One of the main challenge is tracer selection. For example, in the CELI trial, Indosian in green alone show a detection rate about 60% in a cohort of 169 patients. In contrast, the combination of technetium and ICG achieved a detection rate close to 19% in the MELISA trial. Also, the result was based on a smaller sample of 30 patients. Sensitivity is another concern. In the CELI study, it was around 73%, which suggests that approximately 1 in 4 patients with nodal metastases could be missed by a sentinel lymph node biopsy. So while the concept is promising, there are still clear limitations that need to be addressed. This will likely improve over time and as techniques are refined and more data become available. Several questions also remain open. Which patients are the best candidates? Which histologic subtypes are most appropriate? At which stage the technique should be applied? And how the approach case with suspect bilateral tumors. These issues need further clarification. Um, and I think that finally an essential next step will be the evaluating of long-term oncological outcomes in this setting.
Okay. So now, Santiago, as the last question from our fellows, based on all this work that you've done, on your review, on what you found in the literature, what's out there in the guidelines, um, can we just go to ipsilateral pelvic lymph node dissection already and proceed with this as appropriate staging for patients?
Our findings suggest that an ipsilateral only pelvic lymph node dissection may be a reasonable approach. However, it's important to emphasize that this conclusion is based on low quality data and heterogeneous patient population. And in addition, we were not able to fully assess the risk of contralateral pelvic node involvement when stratified by histologic subtypes or tumor grade, as I mentioned. Therefore, these results need be to validate in maybe with well-designed collaborative prospective studies is possible. Until stronger evidence becomes available, we should continue to follow the current clinical guidelines.
Okay. Well, Santiago, as last question, of course, now we come to anticipate, is the question from AI after AI read your paper. And the question is, if the overall lymph node metastasis rates are about 10.8% and isolated periodic metastasis is 5.4%, is contralateral pelvic omission truly about oncologic safety or about surgical convenience, especially in an era when sentinel lymph node mapping is still investigational? And I'll add to that, some might say, well, if I have a patient that on that ovarian frozen section shows a high grade serous carcinoma, I know I'm going to give her chemotherapy. Why even do a pelvic dissection or a periodic dissection? It shouldn't matter in terms of oncologic outcomes because even in advanced stage disease, as shown by the Lions trial, it doesn't impact oncologic outcomes. So why should it impact in early stage disease? So long question, tagging on to the AI question, but would love to hear your thoughts.
Yes, thank you, Pedro. I think that if we are thinking in perform a unilateral pelvic lymphadenectomy to allow the detection of occult nodal disease, I think the omission is truly about oncologic safety and is not about surgical convenience. And perhaps in the future, we will do or perform a sentinel lymph node. Uh, but I think that it's not for surgical convenience. As a gynecologist, oncologist, we are dealing all days with pelvic lymphadenectomies, and it's a procedure that the gynecologists, oncologists perform very well. So I think is thinking more about oncologic safety that yeah, rather than surgical convenience. And respect the other part of the question, I think that um, we some gynecologists could argue that if you are performed or if you are offered uh, um, a chemotherapy in high grade serous carcinoma, so we don't perform a lymphadenectomy, but we need to remember that if we detect occult nodal metastasis, and if you have a high grade serous histology, perhaps this patient could benefit from maintenance therapy. And in um, there is a currently ongoing randomized controlled trial, the LOVE study, and is evaluating that perform versus not perform lymphadenectomy in early stage ovarian cancer that need further chemotherapy adjuvant. So we need to wait for that results, and that could help us to clarify this topic.
Excellent. Well, Santiago, thank you very, very much for having this discussion with us. As you mentioned, obviously it's a topic that has been attempted to be addressed in multiple retrospective studies, and you mentioned the flaws of those particular studies. I think, of course, obviously we want to continue following the guidelines and hopefully provide additional evidence in the future to de-escalate the staging and minimize morbidity for these patients. So again, thank you. Again, congratulations to the co-authors, and really grateful for your accepting this invitation.
Thank you, Pedro, again for the invitation.